Hey guys, this is Derek Storrs. This is my case presentation on chronic low back pain. Patient is a 27-year-old female corrections facility secretary. I examined her on April 29th. She was referred status post L5 discectomy on the 12th. She was formerly preparing for police officer training. Her chief complaint is an approximate 1-year history of low back pain. Date of injury was a motor vehicle accident in January of last year. There are her photo scores. Her P1, 2, and 3. P1, central L5 region, described as constant, sharp, stabbing, burning pain, kind of described it as everything. 6 out of 10 on average. P2, left buttock and posterior thigh, intermittent, vague, deep ache, usually a 3 out of 10, but occasionally can be sharp with quick movements, up to a 6 out of 10. P3 is into left toes, all 5 of them. She's actually had this numbness and tingling, kind of vague pins and needles sensation since before the low back pain, but it has gotten worse. Relationship between symptom areas. Buttock and posterior thigh symptoms, as well as the numbness and tingling in the toe, are affected by the low back pain. Here are some areas and structures to consider. As far as hypotheses, primaries, status post L5 discectomy with some of that residual pain from the surgery and the like. Secondary hypotheses would be that chronic mechanical low back pain that she's had for approximately 1 year, as well as sciatica or lumbar radiculopathy, which is suggested by the L2 and L3 radicular symptoms. Also, spondylolysis or spondylolisthesis has not yet been ruled out. Ags and eases. P1, bending, lifting, twisting, pretty much any movement makes it worse, up to an 8 out of 10 from 6 out of 10. Eases, lying on either side with knees bent, kind of the fetal position. P2 ags, lumbar flexion or the quick movements, which I mentioned, can bring it up to a 6 out of 10. And eases are avoiding the ags and rest. P3, prolonged walking, seems to aggravate, as well as kind of those quick movements that were aggravating of P2. Easing, avoiding and rest. Sleep and 24-hour pattern. She does wake 4 to 5 times a night, but symptoms are relieved with positional change. Generally it's stiff at the L5 region in the morning, but very minimal with P2 and P3 symptoms. However, all 3 symptoms do intensify throughout the day and worse at night. Duration of symptoms, 1 year. The mechanism of injury was actually a motor vehicle accident in January of last year, which resulted in WOD and a right rotator cuff tear. The low back pain she didn't actually notice until about 3 months after, which would have been April of last year, and then it's steadily gotten worse since then. Significant prior history, nausea, fever, chills, and sweats. She reports all of those since the surgery, and then a 15-pound weight gain, which I'll go into more detail. Now here's the one thing that was kind of interesting. She's had 40 physical therapy visits during 2012. Some for the rotator cuff, some for the WOD, but mostly for the low back pain once it started in April. She's had TDN, lumbar stabilization, manual therapy procedures. She's also been taking ibuprofen and Vicodin. That's mostly been since about November. And then she did have a CSI in the right shoulder and one in the low back. So we can see she's done a fair amount of conservative care and then went to the surgical option only after exhausting conservative care. Medical history, I meant to write nothing outstanding. Now the fever, chills, and sweats, dizziness, nausea, vomiting, she attributes all of that to the medications that she's been on, and that kind of comes and goes. As far as the recent weight gain of 15 pounds, she doesn't have anything else that would raise red flags for cancer as far as history of cancer, age, anything like that. She attributes the 15 pounds to not being able to do much over the last year because of her back pain, which has gotten worse. She does have elevated fear, but negative with the depression screening questions. She had the MRI in November, which revealed a mild vertebral fracture and the associated disc herniation, and actually has a follow-up MRI in 2 to 3 weeks, not a firm date, but she's had increasing P1 and P2 symptoms after twisting in the shower. P2 had gone away quite a bit for about 3 to 4 days after the surgery, but then came back after twisting in the shower, and so she's pretty fearful that she's re-ruptured something, and the medications are good. These will be the asterisk signs that I'll use. P1, 8 out of 10 pain when flexing or extending the spine. P2, 6 out of 10 pain when, again, performing those sudden movements. And then P3 usually starts about 5 to 10 minutes of walking, and again, it's just that nagging, vague pins and needles, not really pain. So my hypotheses now have remained the same. As far as ruling out any hypotheses, there's none that I've ruled out. Clinical reasoning. P1 is severe. It restricts her ADLs, her gait speed. She's very highly guarded. She can't participate in her job. She's off work right now, unable to sit or stand for prolonged duration, and actually unable to walk without increasing her symptoms. It's pretty debilitating. P2, not as bad as P1, but again can be debilitating because it's so sharp when it occurs. And P3, pretty mild. The irritability, P1 is severe. There's not much that she can do. A few degrees of flexion, extension, side bending, which I'll talk about later. Moderate as far as P2, quick movements, again bring on those symptoms. And then reviewing primary nature, neurogenic, musculoskeletal, I think there's some involvement from both, soft tissue wise and the nerves. Stage of disorder, subacute flare-up of a chronic condition. She's had this ongoing for some time. And all three symptoms are stable and reproducible. These will be some things that I'll try to rule in and rule out. These will be my tools, using hip and lumbar spine range of motion to see what symptoms are provoked and at what ranges and how severe they are. Neurodynamics, and then heavy use of palpation as well. Patient is cleared for physical therapy. She is highly guarded, has that slight decrease in her lumbar lordosis. As far as quick screening tests, go through active range of motion, passive range of motion over pressure of the hip, make sure that there's no involvement there. Neuro exam, myotomes were normal, but she did have some decreased dermatome sensation to light touch at L2, L5, and S1. Just to briefly review the range of motion, you can see that flexion and extension really increased that P1 to 8 out of 10, whereas side bending and rotation to both sides stayed pretty consistent at a 6 out of 10. No significant change. P2, as far as those left leg symptoms, those were also increased with flexion and extension, and not nearly as much with rotation and side bending to the right, but a little bit more rotation and side bending to the left. Those numbers are correct, 15 degrees of flexion and 5 degrees of extension. Again, she's very highly guarded. I don't believe that that's her end point. That's an empty end feel. It's the pain that stops her from going further. I did not take range of motion measurements on rotation or side bending. Palpation. Prone central PAs to that L spine. The entire L spine reproduced those P1 symptoms and immediately released or eased when I released that pressure. Firm palpation to those glutes on that left side reproduced those same P2 symptoms, and that was more of a gradual easing. When I released, it took not quite 30 seconds for that to go back to that baseline of 3 out of 10 with the P2 symptoms. General hypomobility in the entire spine on prone PAs. And then manual muscle testing, I didn't do any specific core as far as abdominal or back extensor manual muscle testing, just due to patient irritability and concerns of wanting to get to treatment. Muscle length not tested. A couple special tests there. Again, hip looks good. Faber and Fader, scour all negative, but did have that bilateral straight leg raise, which reproduced P1 and P2. That was on that left side. I didn't do the crossed straight leg raise, or rather, it was didn't reproduce those same symptoms. Primary hypotheses following the physical exam. My hypothesis is that it's that status post L5 discectomy after having unsuccessful conservative care. Her signs and symptoms are consistent with mechanical low back pain and associated soft tissue tension. Some things that lead me to believe that are the decreased lumbar spine active range of motion. I can reproduce her symptoms with palpation. She's got that positive straight leg raise, and then trigger points all up and down both sides of that paravertebral musculature. Perhaps a little difficult to make a full assessment just based on how guarded and how much pain she's in. So historical asterisk items, 8 out of 10 pain when flexing or extending, 6 out of 10 P2 symptoms when performing sudden movements, and P3 greater than 5 to 10 minutes of walking will increase that numbness and tingling. And then for the physical exam, some things I want to keep an eye on are lumbar active range of motion, use that as an asterisk item, and P2, the straight leg raise, and the palpation of that glute med and min. Plan of care, she has a good prognosis. I did not put excellent based on the fact of how chronic it is during this course of care, which I project to be 8 to 10 weeks. I don't know that I'll see full return to recovery, but I feel that full recovery is possible in the long term. I'd like to see her twice a week for 3 to 4 weeks and then taper off. My specific goals will be to reduce the P1 symptoms to a 4 out of 10 rather than a 6 on average in 2 weeks, attain a non-antalgic and non-guarded symmetrical gait in 4 weeks, increase lumbar flexion and extension to within normal limits within 8 weeks. She's limited to 15 flexion, 5 extension, and then that the patient will be able to lift greater than 50 pounds to prepare for officer training within 10 weeks. I'll know that she's ready for discharge when she completes her goals, returns to work, and independent with HEP. If she's not making progress after 4 visits, if things worsen, if that nausea, fever, chills, sweats seems to get worse, refer her back to the primary care physician. And my overall management strategy will be to focus on using manual therapy, mobility of the lumbar spine, and some stretching to really get her loosened up and decrease that pain over the next 2 to 3 sessions. Also, add in nerve glide techniques, neural dynamics, trigger point dry needling, desensitization techniques to start dialing down that pain. Once we get to that point, throw in the core strengthening and neuromuscular control exercises so that we can begin to increase that strength, and once we get that mobility to increase. And if you have any questions, feel free to post.